you live from the Fertility Institute of Hawaii. I'm Anat Carmon.
I'm Dr. Goulet.
John Carrell. Hello.
Okay. So we're on two different screens. We're in the same office. We are all a part of the Fertility Institute of Hawaii. But Dr. Fraterelli wanted to be all by himself in his office and not squished in with us here. So, so that's why we're on separate screens. So today we're going to be talking to you about ovulation induction and all that entails. And we're also here to answer your questions live. So as we talk, please feel free to interrupt with questions and we'll be able to answer anything that you guys have. So maybe one of you guys can start with, what is ovulation induction?
Well, first of all, I think thank everybody for coming, and happy holidays, everybody. Happy New Year. And that's going to be coming up, and hopefully it's going to be a better year than what we've had this year. Hopefully everyone will be safe and healthy and happy in the upcoming year. And ovulation induction is vital to a better year than what we've had this year. Right? Without ovulation, if you don't ovulate, then and so you have to somehow if someone's not ovulating on their own, you have to give them some medications typically to help them ovulate. So normal ovulation would just require your normal menstrual cycle or releasing hormones, FSH, follicle stimulating hormone that comes from the pituitary, goes down to the ovary and causes the follicles to grow. But sometimes that's not happening appropriately for women, or not happening appropriately enough. And so then there's medications that we can use and different therapies that we can use in order to try to facilitate that ovulation. And maybe I'll let Dr. Goulet kind of talk about those.
Yeah, we have a lot of medications in our toolbox. One of the most commonly used one, it's been used since the 1950s, is a medicine called Clomiphene Citrate, otherwise known as Clomid. It's so common, it's even on the Walmart $4 list, although we typically prescribe doses that require 2 or 3 of those $4 chunks. Another medication that we also use is a medication called Letrozole, and that's used off-label. This medication was originally invented as a breast cancer medication, but it works extremely well for ovulation induction as well. But I just want to mention that because it was invented as a breast cancer medication, sometimes patients get a little bit concerned when they read the labeling on it. Don't use if you're pregnant. We've used it for many, many decades trying to get women pregnant using it. It's very effective. We've got fantastic data on it, so you don't need to worry about any labeling on that package.
I do want to point out something about conceptually ovulation induction and the indications and how we use it. So what Dr. Fraterelli was talking about is some women don't ovulate regularly, and so then we use this medication to help them ovulate. Sometimes we use ovulation induction actually quite commonly for women who do ovulate regularly. And so I have this a lot. I have patients of mine who I say, okay, we're going to use Clomid and we'll get you started next month. And then, they always ask this question like, but didn't you just say that I ovulate every month? Why are you giving me medicine to make me ovulate? Am I missing something? And so conceptually, although it's the same type of cycle, we have ovulation induction and we have superovulation. We sort of use, we use these things interchangeably at times, but really conceptually, ovulation induction is when we are helping a woman ovulate who doesn't ovulate regularly. Superovulation is when we give this medication to women who are early ovulating. And we still use the same types of medications, oftentimes in similar dosing, but this time what we're trying to do is improve their ovulation. We're trying to help potentially increase their hormone levels. We're trying to help them possibly release more than one egg. We're trying to increase the chances overall of them having a successful implantation and subsequent live birth. And so sometimes women who have unexplained infertility or a lower ovarian reserve or issues such as this mild male factor, utilizing these medications, even though they do ovulate regularly, can help to improve their chances for conception.
Can I take this as an opportunity to bring up, there are some other meds that we often use in conjunction with both the clomiphene citrate and letrozole. These medications might be something like metformin, bromocriptine, or injectable gonadotropin. So depending on each individual's specific fertility scenario, we will definitely customize things as much as we can to help make that ovulation as good as possible.
Right. And you mentioned injectable gonadotropin, so that's kind of leads back to what I initially was talking about with the FSH coming from the pituitary to allow to the ovary to allow for follicular growth. So that's what the gonadotropins are. You know, FSH, follicle stimulating hormone, and sometimes LH, luteinizing hormone that we can administer in an injectable form, typically a subcutaneous shot that the patients would take. Those medications are however much more expensive and require more monitoring and closer following than the oral medicines. If for patients who have insurance coverage for fertility treatment, for ovulation induction, the injectable medicines require a prior authorization. So we have to get approval from the insurance prior to administering them. Whereas with the oral medicine, we typically don't. We usually get started very quickly and very rapidly.
Yeah, and the injectable medication, the major, so it's oftentimes more successful than the success rates can be higher than with oral medication, depending on the indication why we're using them. They're more potent in a different way. But we also have a higher risk of multiple pregnancy. So that's why we're a little bit more careful and do more monitoring. So I think in our hands, they're very safe treatments because we do monitor and we do ensure that you're getting the right dosing. But overall, there is, kind of a higher risk for multiple pregnancy with those treatments.
Dr. Carmone, how do we monitor our patients closer when we're doing those gonadotropins?
Well, Dr. Goulet, that's a very good question. I'm so glad you asked that. We may do a couple more monitoring visits. So with gonadotropins or with the oral medications, we typically suggest doing ultrasound, sometimes blood work, to evaluate how many follicles a patient is developing and how the follicular growth is going. With the oral medication, patients do have the option to take the medication and not be monitored, although we do suggest monitoring for a number of different reasons, but they do have the option to take it, not get monitoring, monitor their own ovulation, time intercourse that way, or come in and have IUI done depending on what the plan is. But the risk for multiple pregnancy is relatively low with the oral medication, such that it is not kind of a requirement. With the injectable medication, we need to see how many follicles the patient is developing. We need to see that on ultrasounds, and we need to evaluate their blood work, also to evaluate how high their risk is for multiple pregnancy and other such complications. As such, with the oral medication, we oftentimes give them medication, have them come back in a week. With the injectable medications, we may have them come back in 5 days instead. So we will kind of do 1 or 2 additional visits with them with the injectable medication. We also tend to monitor the blood work more closely. With the oral medication, we don't have to. With the injectable medication, we also have the ability to turn down or turn up the medicine. So that's another thing, is we see them for visits, we see our patients for more visits, because we can actually adjust the dosing of the injectable medication when we see them. With the oral medication, it's kind of a standard dose that you get initially, and then it's not really adjustable later on because it's only taken for a few days in the beginning of the cycle.
A lot of our patients, even though they are doing mostly either the Clomid or the Letrozole and doing only oral pills, we do usually recommend a single shot at the end of the ovulation period to help guarantee that ovulation. It's called a trigger shot commonly. We have different types of trigger shots, but it is an injection. It's a one-time shot that you will give yourself in your belly area.
Yeah, so that's another subcutaneous shot that we give. And one of the reasons we do it is for timing purposes. That way we know exactly when the egg's going to be there, and whether you're having intercourse or we're doing IUIs, putting sperm into the uterus, we know that the sperm and the egg are there at the right time. And so that gives you the optimum chance of getting pregnant. I guess one of the other things I would say, and I usually when I talk to patients about ovulation induction, one of the first things I always tell them is that really what we're doing is we're trying to optimize what normally would happen. We're just trying to make sure that you're having a good ovulation, that there's an egg there. We're timing it so that the hormone levels are good, uterine lining is good, the egg's there when the sperm's going to be there. So we're just really optimizing what would normally happen naturally to see if that will get better fertilization. Dr. Goulet, you mentioned something about bromocriptine and metformin earlier. Can you explain why we might use those?
Right. So there's reasons why some women are not ovulating or ovulating optimally in every scenario. And so one circumstance, especially if you have what we call anovulatory cycles or PCOS, or your cycles tend to space out for months on end, we've got good data that shows metformin can help make those, can help synergize with letrozole or with clomiphene citrate to increase the number of ovulations. So, you know, it's a very cheap medication. It's well tolerated, and if it can help us get you pregnant faster, then we certainly recommend it. The other benefit with metformin is it often kills two birds with one stone, because in many individuals with PCOS or anovulation, we see insulin resistance. And metformin was initially invented as a diabetes medication. And so for individuals who may be pre-diabetic or even diabetic, it's a great adjunct to their overall whole body health to add to their medication regimen. Oh, and then the other medications, so bromocriptine, for example, that you mentioned, we don't use bromocriptine quite as often as cabergoline, but there are some individuals who've got a pituitary prolactin issue. And it's not that they don't have the capability of ovulating correctly or normally, but we need a different type of medication to correct that hormone imbalance. And once we give them those medications, they're able to ovulate. We are able to induce ovulation induction, and they can ovulate with that.
And I guess, Dr. Cremona, just so we don't just seem like we want to treat everyone with medication, sometimes there are times that we'll do natural cycles, correct? Can you talk about how we would do that?
Sure. So natural cycle is another thing that some patients would like. And I think, you know, obviously it depends on the indication. So if a patient is anovulatory, in other words, if the patient is not ovulating regularly, well, a natural cycle not giving medication doesn't make much sense. But if a patient is wanting to proceed with intrauterine insemination with donor sperm, doesn't really have major fertility problems, or if the main issue is thought to be a male factor where they're being treated with intrauterine insemination, but the female factor is thought to be less of an issue, then utilizing a natural cycle makes a whole lot of sense. With natural cycles, we do some monitoring to check to see when a patient is ovulating, how the patient is developing their follicle. We may still choose to give that trigger shot to help with the timing and help support early pregnancy. And so what we'll do is just do ultrasounds, we'll do the trigger shot, and then we'll do an intrauterine insemination. Natural cycles don't work very well if a patient has a reason for ovulation induction like low ovarian reserve or unexplained infertility. Then the recommendation probably is to start with a medication. But of course, we're open to, I can be convinced, of almost anything as long as it's safe and makes some type of scientific sense. I think all of us are willing to entertain different types of cycles for patients. I think we haven't yet covered how long an ovulation induction cycle can take. Patients are always curious and we want to respect their time. So how many times do they have to come in? How long does this take? No matter what we do, whether we do a natural cycle or use medication, the idea is that we're kind of mimicking a natural cycle. So The average length of time of the follicular phase, meaning the initial time to ovulation and intrauterine insemination or time intercourse, would be about 2 weeks. And then there's kind of a 2-week wait for a period or positive pregnancy test. And so that is how we kind of treat these cycles. Now, this also depends on the patient's indication and how sensitive they are to treatment. Somebody who has what's called a hypothalamic dysfunction, so someone who has an issue where they're not producing FSH and LH and we have to give them medication, this is actually less common, one of the less common indications for ovulation induction. In those patients, their ovulation induction cycle can be like a month, 30 days of giving them just medication, and it can be kind of a long haul, but on the other hand, the treatment is very effective for them. For patients who are undergoing superovulation because of unexplained infertility or, kind of a lower ovarian reserve or somebody with a mild male factor, in these patients, we would expect that, their initial follicular phase would be about 2 weeks. So they're taking the medication, and then on average, they'll have sex or have an IUI somewhere between cycle day, 10 through 14. Which is very similar to how it works in natural menstrual cycles.
Another question I frequently get when it comes to ovulation induction is regarding inseminations, because we often recommend an insemination in conjunction with an ovulation induction cycle. And depending on the scenario, we may be able to offer trying home intercourse first, but there's a lot of advantages to going straight to a insemination in conjunction with the ovulation induction as well. One of the reasons is it does boost the fertility rates. It does help increase the rates of conception. Furthermore, if you are eyeing something like IVF down the road, if these fertility treatments don't work, many times insurances do require that you've attempted some intrauterine inseminations before they'll give you the green light to do an IVF cycle.
Right, and obviously, again, we wouldn't require you to do inseminations if your fallopian tubes are blocked, or if it doesn't make sense to do medically, then it's not going to be required, usually, for the most part. But
yeah. What about success rates with ovulation induction? The obviously there are different success rates depending on what somebody's doing, right? If they're doing natural versus gonadotropins versus oral medicines, but I think the thing to realize is that there is kind of a finite success rate that's given with ovulation induction, because again, we're going back to trying to optimize what happens in a natural cycle. And someone in their 20s may have a natural pregnancy rate every month of somewhere around 20 to 25%, but that declines with age. And once they get into their 30s, it's in the teens potentially, and once they get to around 40 or so, it's going to be less than 5% per month. And so with what we're doing with ovulation induction, we're really getting it back to that point a lot of times, and maybe nudging it a little bit higher. But it's not really, it doesn't really improve things much more than what they would normally have if they were just a fertile patient at the age of 42 or 38 or 32 or however old that patient is.
Yeah, so I think that's such an important point because sometimes this can be really a heartbreaking process, especially if patient expectations aren't really there. So the kind of ceiling to success rate with intrauterine insemination is 20%, and per try for the most part, right? And that's a good success rate for intrauterine insemination. That's assuming that somebody has really a very mild fertility issue. And so it's really important to know that even in the best case scenario, 80% of the time, someone is not going to be successful. And you rarely hear us talking in such really depressing terms because it makes everyone sort of sad about it. But intrauterine insemination is a journey. You have to look at the cumulative success rates, the success rates over time. So if you keep getting that 20% per try, the hope is that at some point it'll work for you. And if it doesn't, it's time to move on to something else. These kinds of low-tech, safe treatments are typically first steps for people. And oftentimes it's all that's needed, but sometimes we do have to move on to something else. And so I think I always try to set the expectation that, this is a journey, and it's not like, that you don't necessarily get pregnant with the first insemination. Even if everything is done correctly, everything is timed correctly, everything goes perfectly, we are limited by the limit of human reproduction.
One of my favorite quotes is, the definition of insanity is doing the same thing over and over again and expecting a different result. And so if you've been trying for months and years at home and you're not getting pregnant yet, then it's time to do an intervention like ovulation induction. And the same thing with ovulation induction. After 3 or 4 months of trying, statistically, things are in your favor that you should be pregnant by then. So if you're not, at that point, we often recommend a different treatment.
And I think that also very much depends on, so I keep cutting off John, but I think it does depend on.
That's the case all the time.
Yeah, that's just you. So I think that it depends on the indication, right? And so if somebody is doing well with ovulation induction and they are ovulating, they have good follicular activity, their development is good and everything looks okay, but they haven't gotten pregnant, after 3 or 4 tries, I recommend talking again. We kind of have another follow-up and say, all right, what should we do? Should we move on to something else? Should we continue this type of treatment? And I do want to reassure patients that, oftentimes they'll have that option to continue doing ovulation induction. Doesn't mean they have to stop and do something else more technologically advanced. It just means it's time to reassess and see if there's anything else that can be added or changed, just to try to optimize things and, again, reset expectations.
Right. I think it's important to realize too, when we talk about success rates with ovulation induction, and depending on, maybe 10%, 15% in that range, depending on or even lower depending on what they're doing. It's kind of a population statistical success rate, not necessarily an individual. Like Dr. Goulet said, if patients are going to have success, they have success within the first 3 to 4 tries. Well, that means their success rate was not 10%. Okay. Success rate was a lot higher each time, but you're lumped in with all the other patients who may not be the best treatment for, and may need to do something more invasive like IVF. And so, as Dr. Goulet said as well, because patients, if majority of the time you're going to get pregnant within the first 3 to 4 tries, if you're not pregnant at that time, you don't necessarily have to move on to the next step, but at least you need to kind of look at your options and see if there's any other testing that may not have been done, that needs to be done now. Was the semen analysis not done? Did we not look at your tubes, or somebody not look at your tubes because you were just trying to get pregnant really quickly first? And so you just have to have another reevaluation to discuss the next steps after that. I guess one of the other things I don't know if we've covered yet, I don't think we've covered yet, is maybe the side effects from medications and some of the treatment. Maybe Dr. Goulet or Dr. Carmel, maybe you guys can address that.
Well, the good news is that the oral medications are generally very well tolerated. Common side effect complaints can include headache, maybe some irritability or mood swings. With Letrozole, the data says that it can be bone pain, although that data comes from our cancer patients. So probably not an issue for most of our fertility patients. But in general, we just use it for 5 days. And so a lot of the side effects that people are concerned about, will I have bad morning sickness for, 5 days? No, it's a short-term scenario. Plus, oftentimes easily treated with things like Tylenol if you do get a headache from clomiphene.
Hot flashes.
Oh yes, hot flashes. Yes, because we are tweaking the hormones a little bit with these medications. And then with the trigger shot, that usually some local irritation, a little bit of pain, and a little bit of redness around the injection site. That medication is very similar to pregnancy hormone, or it may very well be HCG pregnancy hormone. And so some of the side effects with that, nausea, bloating, irritability, fatigue, are also common side effects.
Yeah, and I think it's also important to let us know because we can, and most of our patients are good with this, but we can switch around medications, right? So if somebody really isn't doing well with letrozole because they're having a lot of hot flashes, sometimes they'll do a little bit better with Clomid because letrozole can really drop your estrogen level initially. Clomid works a little bit differently. Or we can use the injectable medication. I think some people actually are less symptomatic with the injectable medication than the oral medication, and some vice versa. So it does depend on a patient's personal type of reaction to it. The actual serious risks and side effects with this treatment are very, very rare. With Clomid, with the oral medications, essentially the thing to look out for would be severe headache, blurry vision. If you take oral medications and you have that, we would tell you to stop it, not take it again. Again, the mild headache and the hot flashes are not an issue. Ovarian cyst development. So what we're doing is we're giving you medicine that's stimulating the ovaries. And so your body can, kind of, I don't want to say react. It's not necessarily an ovarian hyperstimulation syndrome, but the ovaries can sort of get a little too excited about it. Sometimes overreact. Sometimes we see those cysts, even after a period, we can potentially still see the ovaries reacting to this type of treatment. And so this is not really serious. This is just something that may delay a cycle. We may say, you know what, you should probably just take a month off and rest while these ovarian cysts resolve. That can be frustrating to patients, but as long as they understand this is not really a dangerous complication, it's just sort of a potentially frustrating side effect. Ovarian hyperstimulation syndrome, on the other hand, where patients kind of over-respond to the treatment, they can get sick, they can develop some fluid buildup, and very, very large ovaries and ovarian cysts. This complication is almost, I don't think I've personally ever seen it with ovulation induction. This is something that's rare even with IVF and using high doses of medication. And so I don't think it's more of a theoretical concern really with these treatments.
And and one of the other risks I think that we see probably most commonly, except for maybe hot flushes with Clomid, is that the cycle not working, where the patient's not responding to the medication, and we're not getting a response from the ovary, or potentially the uterine response is inadequate, and we're getting a very, very thin lining. And sometimes that will happen with Clomiphene Citrate, and we'll need to switch to another therapy. And oftentimes a different therapy will cure that. The uterus will respond more appropriately with maybe Femara or Letrozole as opposed to Clomid sometimes, or even injectable medicines. And so there are times that, for instance, we start a cycle and we have to cancel because either you're responding too well or you're not responding enough, and then we have to adjust the dose with the next cycle.
What do you guys think about using ovulation induction medications when it's a fertility problem on the male end? Maybe Dr. Carmone or Dr. Fraterelli can speak up if there's a male factor issue going on here.
You mean for using the medications on the male himself?
Or on the female. So I often get patients say, but I'm not infertile. I don't have a fertility issue. It's him. Why do I have to take these medications?
Well, I basically tell them you don't. If you're ovulating appropriately, you don't. However, the treatment for a male factor is superovulation IUI. So we still would recommend making sure that you're ovulating really well and doing an IUI and putting sperm into the uterus when it's appropriate. You can certainly do a natural cycle. So success rate might be a little bit lower, but if you ovulate well, if you're ovulating normally and your hormone levels are normal and your uterus is normal, and then you're doing a natural cycle would be fine. Although I still would recommend a trigger shot in order to make sure that we're putting the sperm in at the right time for optimizing things. But certainly I think ovulation induction is, I've always recommend the medication way just to make sure that we're having the best ovulation possible. But a natural cycle is certainly an option if that's what a patient desires.
Yeah, I also think that something that patients sometimes overlook and that is very difficult to explain really is that multiple factors are oftentimes contributing. And so sometimes what we find is a male factor issue, which we think is treatable with intrauterine insemination, but there may be a number of other things that we're really not able to diagnose because we're limited in terms of what we can really see. So we can't really see inside the woman's ovaries to see her eggs, even though we have some markers for egg quality and things like that. We're not really looking at those eggs unless we do IVF. We are not able to see if there's not really a good test for cervical factor and things like that. There's not great tests for, fertilization, implantation, all these kinds of things may be contributing to the larger problem of infertility, even though the only thing we're picking up on could be a mild male factor. And that's also one of the reasons why superovulation with medication appears to just have an overall higher success rate than natural cycle if the main concern is a male factor.
No, I agree with that too. I think the just kind of summarize things a little bit for everyone, just realize that ovulation induction, again, is really just optimizing what normally would happen and trying to fix whatever minor issues there are. If it's a major issue, a tubal problem that's severe, or a sperm problem that's severe, IUI is probably, and ovulation induction probably the option for patients. And then those patients who are going to get pregnant usually it doesn't take them long. It works within 3 to 4 months, and if it doesn't, then you're thinking about another treatment. So, and it's usually fairly cheap and not too invasive, meaning that you don't need to have a lot of doctor's appointments. The medication is pretty safe and has very few side effects, and doesn't take much time. Like I said, it takes just a few months to give it a try before moving on to the next step, as long as everything is appropriate. But the first thing you always have to do is an evaluation, a very thorough evaluation. I think we probably skipped that at the beginning. We have to make sure that what the sperm is like, that the sperm is adequate for fertilization within a course of IUIs. We got to make sure the tubes are open, that the fallopian tubes are open, and that the fertility status of the female is appropriate, which is very difficult. Like Dr. Carmona mentioned a second ago, when we do IVF, we get eggs and then we can see what the eggs are like and embryos are like. For a female prior to IVF, we're really kind of guessing a little bit how about the fertility based on an ultrasound and age and hormone levels, but we really aren't seeing what the eggs look like and how the fertilization goes. Unlike with a man, we can say, here's a cup, give us a sample, and let's take a look and really get a good assessment of what his fertility status is. We don't really get that status on the female until the IVF cycle, when we actually can see what the eggs and embryos are like. I don't know what your thoughts are on that, Dr. Galay, Dr. Carmona.
Yeah, that you just summarized what I just said, I think. So I totally agree. Yeah. Anything else that we want to cover? I mean, those are the things that I wanted to cover. Maybe what are some causes of a canceled cycle? Dr. Galay, you can go over that.
Yeah, I think Dr. Carmona touched on that a little bit at the beginning when she was talking about ovarian cysts. So we might give you this medication, and when we bring you back to see how you respond to the medication, we might see that you actually developed a lot of follicles, more than we wanted you to develop. Or when we bring you in on baseline, you could have a cyst that's already present and would make the medication not quite work as effectively. We wouldn't want that cyst to grow. So those are two common reasons for canceled cycles. Dr. Fraterelli, I see you grinning at me.
No, I think there's one more thing I wanted to maybe have Dr. Carmona discuss. One of the things I think we also forgot to talk about, or maybe I just wasn't paying attention when you guys talked. I'm sorry, when you guys were speaking. But I think one of the things that people always ask is cost, right? And so maybe Dr. Carmona, you can kind of cover what's the cost with natural versus oral versus injections. What's it going to cost me?
Good question. That does depend on whether you have insurance coverage or not. The oral medications are pretty inexpensive. Without insurance coverage, they're usually less than $100 at the pharmacy. There are some, like Dr. Goulet mentioned, the Walmart plan, the $4. There's some of the oral medications which are actually very inexpensive with discounts, but usually less than $100. Some insurance plans will cover the monitoring visits, so that means that you'd be subject to the typical copayment with ultrasound. Some insurance plans will cover the injection for the trigger shot as well. So you're looking at relatively inexpensive treatment as well as the intrauterine insemination. Some insurance plans don't cover these things. In that case, we try to be creative about it and charge. Usually the intrauterine insemination ends up being around $200, and then we can figure out if you really need the monitoring or not. Some people with oral medication who don't have insurance coverage may opt not to utilize as much monitoring, and we can see how we can cut those costs down for you. The expectation is that this is going to be a few $100s a month or less. Okay, so the expectation is that this is an affordable treatment for those who have insurance coverage or those who do not. And so this is a very, very good place for most people to start, whether or not they have the insurance coverage for it or not. The other thing that I definitely urge patients to do is to actually ask us. It can be kind of difficult to figure out what they have insurance coverage for and what they don't. So kind of let us look into that for you. I would not recommend calling the insurance company and try and figure this out, because it can be troubling. But we will actually be able to look at your benefit, and we'll be able to see if you have coverage or not. And we'll also be able to give you a pretty clear idea on, how much these visits will cost in the event that you don't have the coverage. And like I said, we have some leeway in how much monitoring we can kind of adjust the cost for you depending on what your budget is. Yeah.
And what about Dr. Goulet, what about neighbor island patients? I mean, because there's a difference between patients who are here on Oahu that we can see very easily, and the neighbor island patients that are not easily seen unless they get on a plane.
That's a great point.
Or do we go over there and see them as well?
You bet we do. So we are over on our neighborhoods of Maui and the Big Island about every 3 weeks on Fridays. And so if you are based on one of those islands, you can certainly look forward to having us do your semen analysis and scans over on those islands. Some individuals who live on those islands do choose to fly into Oahu just for their cycle scans and inseminations, and you're welcome to do that if you want that. But if it's hard for you to get away because you have children, you've got work, you've got other things that don't let you just pick up and leave, by all means, we can certainly tailor a customized cycle for you that doesn't involve as many monitoring ultrasounds, so that you can take your medications at home and maybe take an ovulation predictor kit to see if you are ovulating with that medication, or when you are ovulating with that medication, to better time home intercourse.
Yeah.
Yeah, I think that's important to realize that, for the neighbor island patients, we can tailor it. I think that the success rates are probably going to be a little bit lower because we're not doing it as seeing them as often, or seeing them as watching them as closely. But it probably doesn't justify them flying over and spending the extra several $100s just for an extra % or two, with pregnancy chances. I think that was all the questions and all the. Actually, one, I think, so I guess, Dr. Cameron, when, if you're doing ovulation induction, I guess, when would you tell somebody they need to do IVF instead of ovulation induction?
Well, initial indications would be if they have a very low count, right? Very, very poor motility. If we're really unable to concentrate the sperm appropriately in intrauterine insemination, or if there's a tubal factor, or if a patient has a very low ovarian reserve, and I kind of want them to try the most effective treatment right off the bat. Those are reasons why initially I may suggest that they go straight to in vitro fertilization. But for patients who initially were good candidates for ovulation induction, I usually say after about 3 or 4 tries, it's time to reevaluate and potentially move on to in vitro fertilization. The other thing too is if we're seeing during the IUI cycles, if we're seeing that the counts, we're not really able to concentrate the sperm appropriately. You know, even though the initial semen analysis looked okay, if the patient keeps coming back for IUIs and the counts are low, the total motors are low, then I would recommend moving to in vitro fertilization faster as well. Or if the patient strongly desires moving on to in vitro fertilization because of the frustration of doing these types of cycles that have relatively low success rates per try, that's another reason to discuss moving on to something else. What I hate seeing, and I think all of us hate this, is patients who get burnt out, right? And it's something that can really burn you out. Doing treatments, which are relatively easy to do, but for patients who have this expectation, like every month they're thinking they're going to get pregnant and then they don't, it can be incredibly difficult. And so what I hate seeing is those patients who get burnt out and then they just don't come back for anything. They don't come back for ovulation induction, they don't come back for IVF, they just kind of quit. And really the right thing to do is to stop at that point, reassess, and potentially move on to treatment that's more effective, like in vitro fertilization.
On the flip side, I also see patients who have a perceived barrier that, oh, well, my husband is gone a lot. He's on another island, he's on the mainland, he's deployed a lot. I want to get started with treatment now, but I'm going to have to wait 6 months until he returns. And that's something we can actually work around. So we can have him store sperm here and we can treat you while he's deployed or gone so that we don't have to skip months.
Right. And that can be why we're IVF, depending on where you are. Yeah.
And Dr. Cohen, you said it was very, you said something about being too stressed out and it being just a very difficult journey for some patients. Yeah, I think that's sometimes when I'm talking to patients about ovulation induction as well, I always try to offer IUIs and intercourse as kind of a combined. I think a lot of times when you look at, if you just Google or you do a literature search, you see that the treatments are ovulation induction and intercourse, and then if that doesn't work, you go to ovulation induction and IUIs. What I find is that if you're doing an IUI cycle, sometimes it's a little bit more work for everybody. Okay, we have to have sperm, and we have to, and at the same time that we're going to be doing the IUI, and that's not always convenient for couples. And so I talked to them about the convenience of this. Okay, and so instead of doing 3 months of Clomid or medications and intercourse, and then 3 months of medications and IUIs, I tell them let's do 4 to 6 cycles of a combined, meaning that in the month, if it's a convenient time on Thursday, for instance, to do the IUI, then both of you come in and we do the IUI. If Thursday's not convenient for both of you, well, then you do intercourse. And over the course of 4 to 6 months, hopefully we're getting a little bit of, a mixture of a couple of both of those. And if you're still not pregnant after that time, then certainly we need to relook at it. But I think that lowers the stress level a little bit, because I think people, if they feel like they got to do an IUI, even if they got to take off work, for instance, and other things, it really adds a lot of stress to the process that we really don't want to add to them.
Right.
Not to add.
Yeah, and that's kind of what the IUI can also be, removing a lot of stress from some patients who feel like, timing intercourse is can be really grueling, and stressful just to do that. And so IUI can, on the other hand, take some of the stress out of it by having us kind of take care of that part. Also important to know that you can have sex and do IUI. I mean, not literally at the same time, just preferably after you leave the room, but, and go back home or whatever. But you can have an IUI and then later on that night also have intercourse. And so, we'll never know if that baby was made by the IUI or the regular old sex, So I think that's another thing, because some patients are concerned, like, we want to sort of still do it the natural way, and you still can, the IUI just giving a little bit of an extra boost.
So IUI, just to revisit, stands for intrauterine insemination. And some women are a little bit hesitant about this because it sounds like a very invasive procedure. Any woman who's had a pap smear, I would say the IUIs are easier than that. So if you've been to a gynecologist's office, it's a pretty straightforward visit.
Yes.
Well, Dr. Carmon, Dr. Goulet, I don't know if I have anything else to add to this topic. You guys have done an excellent job today. Thank you. Thank you for inviting me from my office, 50 yards from you or 50 feet from you.
Thank you.
And hopefully everyone enjoyed it. And we will see everybody next year.
Bye. See you guys next year.